So let's go on and talk about Achilles tendon. So Achilles tendon can be divided into two types. One way, when it's a non-insertional tear away from its insertion on the calcaneus, or a tear at the insertion on the calcaneus. And then you can have types of disease of the tendon. There are different classifications. One of the older classifications is the Weinstein classification, where you can have what was called in 1991 inflammatory disease, degenerative signal or degenerative disease, partial tears, and complete tears. So why don't we talk about some of these? So here we can see here's the calcaneus, the talus, and the distal tibia you're all aware of. And here's the Achilles tendon coming down to its insertion on the calcaneus. And the axial images, we can see the bones anteriorly, the Achilles tendon posteriorly. You're all familiar with these changes. But what I want to point out here, if we look at some types of pathology in this area, notice that the fat pad in front of the Achilles tendon here does not have normal fat signal. It has a lot of inhomogeneous signal intensity within it. And this is in an area called the peritenon. Now, the Achilles tendon itself has no sheath here. It's attached to the fat adjacent to it by fibrous connections, and that's called the peritenon. And we get either inflammatory disease or chronic injury patterns with scarring. You can have loss of the normal fat signal here, and it's called peritenonosis. And this is kind of the type 1 lowest grade injury that you can have in this particular area. And if you notice on the axial images, instead of having nice fat here, we have it replaced by scar tissue. So that's peritenonosis. Some people in the past have called it peritononitis, but generally it's it's usually due to scarring from either prior inflammatory disease or prior injury. Here's another example where we can see that there's increased signal intensity within the distal Achilles tendon, replacement of or actually this is a fat suppressed image, so this may be normal fat, but we can see edema in the surrounding soft tissues around the tendon. This turned out to be infectious, so this would be truly a peritononitis in this particular case. The next type of disease are longitudinal partial tears within the Achilles tendon. They're often associated with fusiform widening of the Achilles tendon like we see here. This is a very old case and an early study where we can see longitudinal tearing, a couple of areas of longitudinal tearing in the coronal plane. And this would be type 2 disease, which are longitudinal tears. Type 3 disease in the Weinstein classification would be a partial tear going across the fibers, not longitudinal with the fibers, but across the fibers as we see here. Here's on the sagittal images, and this is a partial tear. Go to the axial images, this is what the normal tendon should look like, and here's the partial tear with increased signal intensity. And generally, when you have tendinosis or partial tearing of the Achilles tendon, instead of having a flat or a comma-shaped appearance to the Achilles, you have an abnormally rounded appearance to the Achilles tendon. So generally, the cross-sectional area may increase in chronic disease, but the fibers have fewer cross-linkings, and they're not as normal. They're not the nice type 1 fibers, which are properly collinear with one another. They become confused in a random pattern, which is all due to scarring from prior injury. And therefore it's weakened. And here's a case where we can see also a tear. It looks like there may be partially involved, but if you go carefully up and down on the axial images, I think you'll find that at no point will the longitudinal fibers be contiguous in this, even though partially we see it here. But this was, well, I guess, I'm sorry, this was also, I thought was a partial tear. Here you can see the partial tear, and on the axial images you can see that there are still some longitudinal fibers intact here. So again, this would be a Weinstein type 3. You can also, with these kind of tears, also get an injury or partial tear to the Achilles tendon. Approximately that may be associated with atrophy of the gastrocnemius as well. And here we can see a higher grade tear. This one goes all the way across and through the tendon with a separation. And here this is a complete grade 3 tear. And many people believe it's important, grade 4 tear, sorry. Many people feel that it's important to determine the length of the tear. A number of years ago, some people used the criteria that if this widening was greater than a centimeter, it might be it might need surgical repair, but if it's less than a centimeter, it might be best treated non-surgically, as we'll talk about in a minute, and John will talk with us about it in a minute. That may no longer be considered an appropriate way to determine whether a tear is surgical or not in this day and age. So this is a type 4, Weinstobbe type 4 injury to the Achilles tendon. This is another type. This is more of a chronic, long-standing grade 4 tear of the Achilles tendon, where you can see it's retracted back on itself, and this is really a chronic atrophic tear with some edema in the surrounding soft tissues. And here's another chronic type tear. Acute tears tend to have very sharp margins or very frayed type margins. These margins are much more indistinct. Here we can see an area where you don't have the tendon, and there are distally retracted, proximally retracted tendons here. And this is the space in between. And this was, this was an acute tear in this particular patient. And here we can see a tear of the Achilles tendon, full thickness tear. This is on 6508. And on the cross-sectional images, we can see a full thickness grade 4 tear of the Achilles tendon, the axial plane, with the plantaris tendon still intact here on the medial side. This was right after the tear, complete tear with retraction. This is now about 3 weeks later, and we can start seeing that there's some fibrous tissue starting to grow in here. And this we can see a year later is a typical healing pattern that we've seen in tendons and ligaments, where you come back with a thickened tendon. Now, typically at this stage, the tendon is not as strong as the initial tendon was. The cross-sectional area is greater, but the fibers are not as strong. They're not collinear like type 1 collagen fibers are supposed to be. They tend to be more randomly oriented with a lot of, and therefore they even though it's a larger cross-sectional area, it's a much weaker tendon than the normal tendon was before it scarred in. The axial images show a nice rounded appearance of the tendon, which is very abnormal. The normal tendon is a little bit more of a thin, comma-shaped structure here. So this is 1 year out after a large tear with healing. John?
Pardon me?
Were you going to say something?
No.
Okay. Robert, what do you think of this case?
Here it looks like there's some pretty high grade tearing of that distal Achilles tendon. And there's some peripheral low signal fibers that may remain intact there, yeah.
Yeah. So there are a lot of different surgical approaches to the Achilles tendon. And when there are a lot of different approaches, it means that no single one is really all that effective. So people have tried a lot of different techniques. One technique to try to strengthen the repair is to sacrifice the plantaris tendon, kind of unwrap it and use it as a collagen wrap around the tendon. Here we can see that this is torn, and this is actually the collagen wrap around the tendon. But what happened, this patient had surgery. A couple of weeks after surgery, re-injured the tendon, tore the tendon retracted, but the collagen wrap is still in place here, but it's not really protecting the tendon. So that was
one technique is to take the plantaris tendon, sacrifice it, and use its peritoneum to you kind of tease it like making a cigarette. And you take a cigarette and you take
yeah.
the paper off, and you can wrap that around in the site where you sutured the tendon. That people think that works. Now, as far as I'm concerned, and I go with the folks from Australia, I don't recommend surgery for this injury unless it's somebody like 16 or 17 years old. You might think about it. Surgery has multiple complications. There are about 100 different ways to do the surgery, different suture materials, different suturing techniques, etc. But the best thing is to treat them conservatively, not in a cast with a leg in a hanging down position with slight flexion. And I usually use a long leg cast, which I would then put in a short leg cast at 4 to 6 weeks, and with a heel, and start walking the patient. Um, some people walk the patient pretty early on, like a week or so. I used to be a little more conservative about it, but they heal even with big gaps. There's a very interesting tendon that it heals quite easily, actually, with gravity. And the strength of the tendon uh, has been compared with those that were repaired surgically, and I don't think there's anybody that's found any difference between the two. Some people, some of the orthopods, think that a calf may not go as low in those that had non-surgical technique of treatment, but I'm not sure I believe that. All the cases that I've taken care of, I've done non-surgically, and I've been very happy with that way of treatment. My partner tried a couple of days with me assisting him, and I said, you better keep an eye on this patient. And the next time he took the cast off after the repair, there was nothing there but an open wound with nothing left but of the tendon. The tendon just disappeared because that's the way it is in this area. The blood supply is terrible.
Okay. Thank you, John. Okay, so Elior, what do you think of this case?
Okay, so here, 59-year-old male, rule out Achilles tear. I think we may be more medial, maybe, but I think there's irregularity in that Achilles tendon.
Okay.
I'm not seeing it. Maybe there's a tear, just
Yeah, the
proximal to
axial
its
image is
insertion.
through there.
Yeah, okay. I'm seeing edema anterior to the tendon and some irregular signal.
And
with
the tendon
fibers.
itself is rounded. It's not the normal comma shaped. It seems to be a little displaced to one side.
This case also is the patient is 59 years old, so probably most orthopedic surgeons would not operate on this.
Okay.
even the sports medicine folks that tried to get these people back to sports wouldn't operate on this.
Okay. And what tendon is
59
this?
is over the hill.
Yeah.
That's the flexor hallucis longus.
Right. Okay. So this is that same. No, so this was on 11/12/08. This was a complete tear with retraction. It's a little bit hard to see here. Uh, and here we can see the tendons kind of pulled off to one side. So then the patient came back, and this is now, let's see, this was 11, so we're, I don't know, 6 or 7 months later, and this is what it looks like.
I don't think this is a technique recommended by Campbell's. I've never done a technique like this. I operated on a few when I was a resident, but this is condemned in my opinion. That's just never going to happen. I mean, never going to heal. A single screw, at least that's all we see is a single screw.
So, Eliar, what do you think?
Right. So they had a flexor hallucis longus transplant, which looks like they had inserted into the calcaneus, and looks like that screw or maybe suture anchor has displaced.
Yeah, so this
Yeah,
is
that's a
suture
suture
anchor.
anchor.
Okay.
They also tried to repair the native Achilles as well, and you can see that the suture anchor pulled out, and you can see that the native flexor hallucis longus has been sacrificed here. Just like you said, they tried to use that to help bolster the repair, but this is a non-intact construct. And here you can see the distal flexor hallucis longus tendon here, where it's been transected in this particular procedure. This is the only time I've ever seen this procedure being used.
I except here, John, I've never seen one either.
Yeah. Okay. Robert, what do you think of this case?
All right, so we have a cadaver graft in a repair on 4/9, now 10 days of swelling and pain. I mean, I see some micrometallic artifact, and that graft looks pretty thick and irregular, and there's some fair amount of fluid anteriorly.
Yeah.
Be considered.
So this is another construct that is torn and retracted. And this occurred very rapidly after the surgery, as you can see. And here is the axial plane with this large fluid collection, probably hematoma collection here, the metallic artifact. And this happened to be the second time surgical repair in this patient tore. And so this again was unsuccessful. Okay, Elior.
Okay, 54-year-old male, surgery a year ago, pain for 3 months. So, yeah, we're looking coronally here. The Achilles tendon, right? There's increased signal. Doesn't look like normal tendon fibers there. Let's see, on the axials. Does this, I think this is another post-operative appearance.
Had surgery 1 year ago and now has had pain for 3 months.
Is this, yeah, so we're seeing a lot of signal and fluid within this, the Achilles, but I think maybe, is it another like a plantaris wrap with the Achilles torn and retracted maybe, or?
Right. And then here's actually the retracted, and the metal here, the tear of the main construct here, but there's also a secondary anterior construct here, which is probably the soleus attached here to the calcaneus.
Failed procedure.
Yeah. So this is another failed surgical procedure. And here you can see there's the anterior suture anchor. And so there's repairs both posteriorly and anteriorly in this patient. Right. Yeah. So, yeah, the part of the problem with radiology is in these postoperative cases, we tend to see the failures. We tend not to always see the successes. But a decade ago, surgery was tended to be very popular, especially on the East Coast. And then now it seems to be becoming a little bit more popular, where I'm seeing more surgery, especially in the young athletes, but still tend to see failures fairly frequently. So I think this is a very difficult area for surgical repair. The primary repair, I think a lot of people feel takes a lot longer, as John was referring to, and therefore the athletes tend to put a lot of pressure on surgeons to operate on these to try to get back to playing sooner, like the quarterback for New York did this year. But it's just this surgery is difficult, and failure is surprisingly frequently seen. So let me just talk about now, instead of complete tears, but the concept of insertional and tendinopathy. Like we've seen in other locations where tendons and ligaments insert onto bone, the histology can be a little bit complicated. Here we can see the bone, the calcaneus to the right. This is the trabecular bone, the cortical bone, and wherever you have a place where a tendon or a ligament may rub against the bone, the body tends to put a synovial sheath in between the two, and this is kind of what it looks like at the Achilles, where the tendon comes down and attaches to the calcaneus. Where you have the cortical bone, you got this cartilaginous fibers on the anterior side of the tendon as well as the posterior side of the bone itself, and a synovial sheath here in between the two to try to decrease the irritation of the tendon directly against the bone. So the insertional tears we've been so far talking about really complete tears, but the insertional tears, the partial tears, tend to be associated with the bone itself. You'll often get a little bit of traction injury to the trabecular bone at the insertion as well, thickening of the distal Achilles tendon. So this is a partial insertional tear where the bone is directly involved in it, as we see there.
And the ideal, I'm sorry to interrupt you, John.
Go
The
ahead, John.
ideal of a case like this, or degenerative partial tearing higher up, is when you see that, you mobilize the patient in a plantar position and let them heal. A lot of people try to treat them with activity, exercise, and passive, active, and so on. And to me, that just doesn't work out. When you get a degenerative tear because of repetitive traction injury, you just have to immobilize it until things quiet down.
Okay.
And so this is an excellent case for somebody to go into a splinter cast and let it heal with time. When the pain is gone, let them back to activity. Maybe get an MRI before letting them go back.
Thank you, John. And these tend to have a pretty high heal rate because, as you know, bone heals very well. Still part of the tendon is attached to the bone and the bone grows in. and heals much more readily than if you just have the tendon separated from the bone completely.
You have to keep in mind that if you have a failure from a patient that you treated conservatively, you can always operate. But once you have a failure from an operative case, things get really tough. So I'm a conservative guy. I've taken care of quite a few of these, and I've never regretted the fact that I treated them conservatively, because I knew I could always go back and do surgery if things didn't work out exactly as I wanted to. Fortunately for me, I never had to do it.
Good, great. Elior,
Just one man's experience.
thank you, John. Elior, what do you think of this one?
Yeah, at the distal insertion of the calcaneus, there is increased signal within the fibers. Yeah, I'd call this tendinosis.
Yeah, I think you call it severe tendinosis. I think you could even call this interstitial partial tear of the insertion. And, it's kind of around 50%, maybe a little bit more than 50% cross-sectional area here. So this is probably a moderate to high-grade partial tear of the Achilles insertion. Okay, this is on 9106. This is 6107, so we're about 9 months later. This was treated as your Gudis would recommend, conservatively. So what do you think now?
Right, it's much more normal shape, more common shape on the axial, with just some residual increased signal. So maybe some mild tendinosis now, or
Give it
Yeah,
more time and it'll heal up.
yeah. So this is scarring and healing, and the patient was asymptomatic at this particular time. Good. Okay, Robert.
All right, we have a 38-year-old male with heel pain, roll out tendinitis. Looks like there's pretty extensive increased signal in that distal Achilles with some partial thickness tearing anteriorly, some fluid in that retrocalcaneal bursa, and some edema in the calcaneus.
Good. Right. Now, yeah. We've
Uh,
talked about
uh,
this.
uh,
Go ahead, John.
this is avulsed anteriorly from bone, and part of the tendon is left attached. So about 3/4 of the tendon is lacerated and avulsed. So my treatment would be the same as I've said before. Um, but these things happen, and usually when it tears completely. But this kind of a teaching case, so that's definitely easy to treat with a cast.
Thank you, John.
Not easy on a patient, and they get frustrated and so on. But they never took orthopedics as a profession, so.
Yeah.
Uh,
Yeah, these take a long time to heal because, as John said, it's not well
yeah,
vascularized
it
here.
always takes a long time, a lot longer than we always think.
Yeah.
It's not an appendix.
Yeah. And you can see the edema within the bone here over kind of a long segment. So this would be a high-grade insertional partial tear, as we said. And here
See,
you can,
the inflammatory process is already at work, I would think, right, John? And
right.
so
Yeah.
the healing process is already there. All you have to do is help it so that it doesn't put tension on it. Tension is the worst thing you can do on a tendon um, when it's lacerated.
So the bone then is you get a lot of granulation tissue, and the bone will grow into the tendon here. Notice also this is a typical location where you can get osteitis of the bone, post-traumatic, and this can lead to hypertrophic bone formation in this location, which we call the Haglund deformity, which we'll see in a minute. Okay, Elior, what do you think of this case?
Right, so we see thickening of that Achilles tendon with maybe a low-grade interstitial tear.
Okay,
And yeah, I see edema within the posterior calcaneus there.
right.
Uh,
So again, that's probably due to traction injury, and we call this insertional osteitis.
What's also interesting, you don't see much skin over that tendon, do you? Usually the skin
Back
over the
here,
Achilles tendon is very thickened and rough.
okay,
It's not normal skin that we usually see.
okay. Robert, what do you think of this case?
All right. So again, it looks like there's some increased signal in that distal Achilles tendon with some retrocalcaneal bursal fluid, and then there's a small bony protuberance in that superior calcaneus. Any concern about a Haglund deformity?
Right. So this is a typical Haglund deformity due to chronic traction osteitis and the stimulation of the bone here it's trying to grow in and heal with that tendon. And if you continue to have traction, you won't get healing, but you'll continue to stimulate bone formation here and you'll get this Haglund deformity, indicative of chronic traction injury to the Achilles insertion.
Ballet dancers are very common to have this, and skaters also do. Ice skating dancers, etc. It's
Okay.
very common. I've seen these as early as 13, 14 years of age.
Wow. Thanks.
Just
Elior,
overdoing something that's worthwhile trying, but
right.
just too repetitive, too stressful.
Right.
right, so 41-year-old right heel pain and swelling for 18 months. So we have the bilateral hind feet. So the right foot, which is on our left, I think we're looking at the Haglund deformity, maybe. No. Or do they have bilateral Haglund deformities?
Yeah. Well, actually, this is actually the asymptomatic, and this is the symptomatic side. Sorry about that.
Okay.
It's not
Okay.
clear. And if you look, this is kind of rounded, and we're starting to get a little bit of a point here on this side.
Mm.
And
Yeah.
that's it
Your
kind of
hands are,
magnified out.
yes, you can have bilateral. In fact, it's not at all uncommon.
Here's the CT scan showing this Haglund deformity here, which has developed probably a little bit of fluid in the retrocalcaneal bursa right there, and this hypertrophic bone formation. And then here also you can see some irregularity of the bone here from traction, erosive changes on the symptomatic side. Here is the MR scan where you can see the Haglund deformity with that little erosive change next to it, though we don't really see a lot of edema right now. And we can see that little erosive change here, right where the tendon attaches to the calcaneus. So in this particular case, they talked about a differential diagnosis to include chronic hemarthrosis, villonodular synovitis, chronic RA, gout, amyloidosis, and so forth. By x-rays, it was really thought to be more of a Haglund deformity, maybe PVNS. This is what it looked like clinically, a little prominent bony formation, and this is the more symptomatic side where it's also very red. Here we can see The Haglund deformities here, probably some rubbing of the feet of the shoes in this location, this hypertrophic bone formation, and this turned out to be, when they went in surgically, these were bilateral, these were Haglund deformities, more on the symptomatic side and less on the less symptomatic side.
Surgery is not without problems in this area. It's like any surgery in the Achilles region. It's
Okay.
you have to be pretty gentle with the surgical procedure.
Okay.
Careful.
And here they're removing some of those fragments. And yeah. Okay. Robert, what do you think of this case?
Here it looks like that distal Achilles tendon is torn and retracted proximally. Pretty decent tendon gap there.
Yeah. And then here we can probably see a little prominent bony prominence here, probably from chronic traction injury and a Haglund deformity before you had the complete rupture. This is probably the plantaris tendon, which may still be intact there. And here, actually, this is probably the plantaris tendon, and then we can see the tear of the Achilles tendon. And this was a distal rupture.
Yeah, about 25% of people don't have the plantar, so
Okay.
it's nice to have it if you're going to do surgery. And sometimes it's a good support for non-surgical treatment also.
Thank you.
It's like a inside splint.
Eliar, what do you think of this one?
Okay, so looking here at the distal insertion of the calcaneus, we have the T1 image on the left. We see some increased signal there. I think there's some retrocalcaneal enthesophytes, and we have edema on the might be the PD fat set image on the right. So maybe some traction edema at its insertion.
So this is 8/2/2018. The patient had symptoms, so they operated. What do you think here?
Yeah, so right, looks like they've secured this Achilles to that insertion site. I'm not seeing all of it. Certainly a lot of edema there now. I wonder if there's a tear or.
Why are you wondering?
Oh well, I don't see all of it.
Yeah,
is it tear?
we didn't
Is
see
it
all the images, but these are the characteristic images. So you can see that they did kind of a double row technique with 4 suture anchors, and this is just going through one of the rows of suture anchors.
All you do with those screws is just damage more tissue, and I've never liked that doing screws in this kind of area for tendons. It just doesn't appeal to me.
Yeah. So this was a post-op rupture of the Achilles tendon.
That's a different story.
Yeah.
Yeah,
And so
well,
you
I
see the
think what
retraction.
happened here, John, is the patient probably tore and fell rather than the other way around.
Okay. That could be. Okay, and here we can see a much more diffuse injury of the Achilles tendon in this particular patient, and this is associated with a lot of atrophy of the gastrocnemius muscle higher up from the chronic tendon tear of the Achilles tendon and retraction.
I would be looking for nerve damage on this case.
Okay. All right. Robert, what do you think of this case?
All right. Let's see. Looks like there's some, again, a high-grade partial thickness tear of the distal Achilles tendon on that first axial image. And there's some edema in the soleus and gastrocnemius muscle bellies. And yeah, I think there's a high grade, if not full thickness
Yeah.
tear there.
Yeah, I think this turned out to be a full thickness tear with retraction here. And what we're seeing are chronically retracted soleus and gastrocnemius muscles, which are now becoming atrophic due to the traction of the Achilles tendon from the complete tear. Okay, and then here's a chronic tear where there's been some healing and some fat deposition in the area of the Achilles tendon. But more of a chronic tear that has not healed properly. Okay, Elio.
If you don't immobilize this, they will not heal.
Okay.
You can be guaranteed of that.
Elio, what do you think of this one?
Yeah, lots of regular signal in the distal Achilles tendon there. Yeah, just a bony protuberance in the posterior calcaneus, Haglund deformity, lots of edema and Kager's fat pad. Is there a suture anchor in the calcaneus there? Or maybe it's
I
just
don't remember what that is.
okay.
Yeah, I don't think this patient had surgery. I think this is a chronic insertional tear where it's basically you have a tear and this is a lot of scarring that's developed in situ. So this is like what we see in the supraspinatus tendon occasionally, or in the subscapularis, where you'll get tears, complete tears. It'll retract a little bit, scar formation will occur, and you'll have having proximal migration of the musculotendinous junction, and you'll have what looks like an intact tendon, though most of this is just scar tissue. So this is scar in situ.
There's really no true connection here that you can rely on, is there, John?
Not really. I don't think this is good quality scar. But this may be a situation like John was talking about where this has tried to scar in and heal, but it hasn't healed properly because the patient has continued to be mobile and keeps injuring the tissue before it has a chance to fully heal.
That's one thing about tendons that's quite different from ligaments. Ligaments like to be stressed a little bit with healing, so you try to not immobilize as long as you have to immobilize tendons, because tendons have muscles, and the muscles go into spasm, and they yank on the tendon and try to pull it away from the bone or whatever. So it's easier to deal with a ligament than it is with a tendon. But if you immobilize and let the patient rest in a cast or a splint, there is no spasm. Spasms don't occur, and that allows for healing.
Hey, good. Oops. Okay. I forgot. Robert, what do you think of this case?
So we have a 45-year-old with bilateral Achilles pain. And it looks, there's a big tendon gap there in the distal Achilles. It looks like a chronic tear. I don't see a whole lot of edema there. The tendon itself looks, I don't see a whole lot of tendinopathy, but.
Right, you don't see a lot of tendinopathy. It's bilateral, which is a little bit odd. And you really don't see a lot of kind of inflammatory changes around this particular area. This should kind of ring a bell. This is actually drug assisted Achilles tears, and this is Levaquin, and some of the antibiotics are known to weaken tendons and greatly increase the risk for Achilles tears, and these tend to be bilateral when they occur.
Like
Cipro is another good example, right?
Yeah, that's the most common.
Yeah.
I suspect this to be a little bit of a cavus foot. What do you think, John?
I'd need to see it more distally. It certainly could be, or it could just be that this patient is extended because the Achilles tendon is insufficient. I'm not sure. I'd have to see the rest of the
Yeah,
foot.
I'm looking up plantar fascia, like
Yeah.
a little dense.
Yeah. We just need to see a little bit more of the bones to
Yeah.
differentiate that. Yeah. So here's a study that was basically asked the question, in patients with acute tendon rupture, are outcomes at 12 months better with or without surgery? And this was published last year in the New England Journal of Medicine. Elior, what do you think?
Maybe without surgery, they do better.
So basically, in this particular study, the outcome at 12 months was the same, whether you operated on them or not.
But they didn't talk about complications, which you do not get with no surgery.
Yeah. Well, I think that the general impression on this article was that since non-surgical uh, uh, patients came out the same as surgical, that their overall recommendation was to treat most patients non-surgically.
Yeah, well, the Australians have been telling us that for years, as long as I can remember.
Okay.
And I had a good friend in Australia, and we used to talk about that quite a bit.
Okay, great. All right. Robert, what do you think of this case?
All right, here there's some retrocalcaneal bursal fluid, some tendinopathy of that distal Achilles tendon. I don't see a discrete tear here.
Yeah. So this is called bursitis, retrocalcaneal or pre-Achilles bursitis, and you can see some distal insertional tendinopathy of the Achilles tendon, and this is reasonably common cause of pain in this particular area, and I think there are two reasons for that. There may be a little bit of a head lug deformity here as well. One could be that you just have traction injury here of the Achilles tendon, which then you get some partial tears of the fibers here, and you get kind of an inflammatory bursitis due to that. The other very common cause in this area is the footwear, where the back of the shoe presses against the Achilles tendon at its insertion here, and you get mechanical irritation of the Achilles tendon and the bursa from the footwear, for the shoe wear. So one thing that people have to be aware of is that shoes can be part of the problem here and have to be evaluated. Okay, Elior.
Right. So here, looking at that distal insertion, the Achilles, it looks like there's some erosive change in that posterior calcaneus. Maybe, small Haglund deformity.
Only a little small Haglund, right. And it gets a little bit of edema in the bone here and a little bit of edema within that distal Achilles at its insertion point. And these are traction erosions at the Achilles insertion. And obviously, if this continues long enough and you get weak enough, you can then rupture and get retraction of the tendon. John?
Most Haglunds that I've seen have been in women.
Okay.
So,
yeah.
I'd just like to add
do you think it has anything to do with high-heeled shoes?
I think so.
Yeah. Okay, Robert.
All right, so we have a 61-year-old with right heel pain for 2 years. Let's see. Looks like there's some thickening of that plantar fascia with edema and a small or moderate-sized plantar spur, maybe large actually. And other than that, the Achilles tendon I think looks okay.
Mm, it's a little irregularity of the calcaneus back there.
Oh yeah, for
And
sure.
probably a little bit of a Haglund deformity here. Here it looks like there's a little bit of soft tissue thickening back there, which I don't
Yeah.
appreciate so much on the MR examination. This patient was rheumatoid factor negative, but was HLA-B27 positive. And this was a patient who had ankylosing spondylitis, and they can also have enthesopathy in this location, like they do everywhere else in the body in patients who have ankylosing spondylitis.
And there's also a plantar spur, and
Right?
podiatrists love to operate on these. Maybe they
Yeah.
don't anymore, but they sure as hell used to.
Well, yeah, it's really frowned upon now, but you're right. And I agree, there's a lot of tendinopathy of that plantar fascia. Okay. Elior.
Okay, 69-year-old female, fell and hurt ankle, incidental calcaneal lesion, not seen on x-rays, but seen on a bone scan. Yeah, we see these bone scans with uptake in that uh, retrocalcaneal region bilaterally. On a CT, yeah, it's just here's some sclerosis there in the posterior calcaneus.
And here's the MR.
Okay. Yeah, in edema there at the insertion of the.
I don't know if that's sclerosis.
Yeah, this is probably all
Yeah.
granulation tissue,
Okay.
chronic traction type injury. And I think this is all granulation tissue here due to traction injury of that bone.
No.
And in this case, they believe that this was primarily pressure from injury from footwear, chronic footwear in this location.
One thing people forget, I used to have mothers ask me what kind of shoes they should get for their kids. And they always brought up the fact that they have to be firm and expensive and leather, etc., etc.
Okay.
And my answer would be get the cheapest you can and make sure that they're like tennis shoes.
Yeah.
But real flimsy, cheap, like a sock that's made out of rubber or whatever. Mothers used to raise their eyebrows, and maybe they went to another doctor. I don't know, but that's what I used to tell
Yeah.
them.
In the next couple of lectures, we'll come back to footwear
Yeah,
and shoes. I think John knows the lecture
yeah.
that I'm talking about,
Just
and we'll talk about that in more detail. Good. Yeah, that's good. Okay. I don't know. Is Ellie or are you next?
I think it's actually me. But
Okay, Robert, you do it.
so we have a 10-year-old male with heel pain. Um, I think there's some fragmentation of the calcaneal apophysis and maybe some edema within the fragmented. So maybe some Sever's disease here.
Okay. And then here are the axial images. We
fevers.
can see that back in through here. Yeah, and this is called Sever's disease. It's also called calcaneal apophysitis, which is also probably a traumatic injury due to chronic stress and traction injuries, because the Achilles tendon comes down and a lot of those fibers also extend down into the area of the plantar fascia. So, especially in younger people, this is a common area where overuse can produce symptoms in patients. So that was Sever's disease, which is traction injury of these structures of the apophysis and the fibrous attachments to the apophysis from the Achilles and the plantar fascia. Elior, what do you think about this patient, 8-year-old?
Right. It looks like the apophysis is I think that's what's retracted proximally there. And there's, the bone protuberance, not a Haglund deformity, but I mean, just this pointed structure there.
And then here we can see further images here where you can actually see it looks like there's been an avulsion fracture almost. The Achilles tendon insertion on the calcaneus there. And then probably some injury also here, traction injury from the plantar fascia attachment.
It reminds me of a ballerina.
Yeah. So these are, and here we can see the MR scan in this individual showing these traction injuries to the bone at the Achilles and plantar fascia attachments. So that these are really traction injuries and fractures of the apophysis. And they can cause a lot of deformity, as you can see, and a lot of pain. And these are typically in athletes, young athletes who are pushed too hard and worked through the pain. These happen to be people, athletes from Korea. And again, we can see this apophysitis or Sever's disease. And in older individuals, you can get chronic heel pain here also with chronic fractures that aren't allowed to heal involving the calcaneus. And here we can see a displaced fracture of the Achilles insertion on the calcaneus in this particular patient, calcaneal avulsion. Let me just see. I think, why don't we stop here and we will start up again tomorrow and start here and continue probably getting through most of the tendon disease tomorrow. Okay? Any questions?
Have a good evening, everybody.
Thank you.
Thank you.
Thank you.
Yeah.